Patient Advocate Foundation, our mission is simply put to help patients one at a time. We do that through direct patient services. We provide direct financial support, and patient navigation to us means case management. So case management, we like to think of it as precision charity for us. So we try to get the right assistance to the right patient at the right time. It starts with a comprehensive individual needs assessment. So we just ask the patient a series of questions and find out what issues are they struggling with as it relates to access and affordability. And then we assess the case, assign it to a case manager, and that case manager stays with that case to try to resolve it in meaningful and important ways to that patient. So it's very personalized. Just to give you a little bit of sense of the patients that we're serving, most of them actually have some form of insurance, so commercial insurance or Medicare. Many of them have an household income of less than $23,000 per year. That's about the average, 2/3 or under $35,000 of household income. It's a racially diverse population, so about 57% are Caucasian, about 17% are African American, about 12% are Hispanic Latino. So it's a pretty diverse population in a number of different ways. The biggest common denominator is the low income nature of those patients. So just to bring a little bit of data forward, and I think this helps inform and shape some of the conversations we're having around cost and value, just open-ended when we ask patients, what are you struggling with? Not what are we going to help you with, but what are you struggling with? The top five things, and the percentages are pretty low because we collect data on so many different things that patients identify as issues. But it's copay assistance is the number one thing, but that's actually for hospitals and providers. So that's the number one issue that patients are saying they're struggling with. Number two is actually transportation expenses. Number three is copay assistance for pharmaceuticals. Number four is inability to afford rent and mortgage payments. And number five is the inability to afford utilities. So cost of living issues mixed with financial toxicity issues. We also do a lot of survey work back into those patients and try to get what's the sense of the prevalence and severity of that financial toxicity. About 90% of the patients we serve in case management say they have financial hardship due to the cost of medical care. So almost all of them have some sort of financial toxicity. How severe? 85% say it's either unable to manage it or very difficult to manage. So very severe financial toxicity. So I bring that up, and then we also ask them those surveys, all right, well, what's the source of that financial hardship? 50 to 60% of those respondents identify one of these four things as a source of their financial hardship, and often identify them. They're able to select multiple things: prescriptions, office visits to physicians, visits to other medical providers, anesthesiologists, radiologists, et cetera, as well as laboratory services. I bring this up because in the context of the value conversations, the frameworks, the quality measures, how much are we encompassing all the different costs that really matter to patients? And in our public dialogue around the issue of healthcare costs, how much are we encompassing and really capturing the range of financial hardships and the sources of those that matter to patients? So then we ask, well, what's the impact? What does it mean to you to have this financial hardship? Well, on their medical care, it's actually what we tend to see is that they tend to find a way to get to their medical care. So about 26% had to stop or postpone treatment. About 26% did not follow the medical advice as prescribed. So it does impact their ability to maintain their medical care, but not as much as it impacts their financial situation. So yes, about 62% do what you would expect. They cut unnecessary or sort of what you might say non-critical household expenses, but then they start cutting their utility bills or paying them late. Then they start, this is the one that just gets me every time, 30%, 37% they are unable to afford groceries. 25% miss their rent and mortgage. 13% miss their car payments. 8% file for bankruptcy. So it actually has a really significant impact on their cost of living situation, more so than their medical care. So at Patient Advocate Foundation, we like to say it starts with the patient and it ends in policy. So we actually have a C4 that's called the National Patient Advocate Foundation. So like I said at the beginning, our mantra is one patient at a time, but then we try to scale that through the data and using that data as a way to look for a policy and advocacy platform that really addresses issues around advocacy and access for patients. So switching then to value, because I think the idea is access to care and what's going to affect access to care. Value is going to drive access in the future. As we shift from volume to value, the value equation and how that's calculated is being translated into things like measure sets and frameworks, and we're going to end up paying for value. We're going to shift from fee-for-service to paying for value, and that's going to turn into paying against measure sets, things like what Gary was saying up on the panel. So who is defining value? Who are the people that are involved in defining value? You're going to hear about value frameworks in the next panel. What variables are we using to, I don't have answers to these questions. These are more rhetorical questions. What variables are, I'm going to answer all these questions in 5 minutes. What variables are we using to calculate value? Are the variables patient-centered? How do we track and measure patient benefits, risks, and costs longitudinally? Do we focus on defining value at the patient level or at the individual level? And who gets to decide what is value for society? All loaded questions. So some of the tension's already been mentioned, so I won't belabor the point here. But there's a couple dichotomies, and these are not necessarily mutually exclusive, and Gary touched on several of them in the panel. You can think about population level versus individual level. And if you think about population level, you're really asking about what are the benefits and costs to healthcare to society at large, or at least large subpopulations. And when you apply that thinking to the clinical level, you get a population focus where you're really determining best treatment options and trying to drive people towards a standard of care against that average. And at the payment level, then you're focusing on benefit designs and payment models that are aligned with what's most cost effective to the average patient. If you flip that over to the individual level, which is where most patients, at the level at which most patients experience their care, you're talking about trying to determine the best treatment option based on the individual needs, characteristics of the patient. And then the payment level, you'd be focusing on payment models that align best with the value to the individual patient. So then you have another tension between personalized care and standardized care that was already referenced as well. So if we're defining quality, value frameworks, measure sets based on a rigid standardization of care, this is again to Gary's point, then the treatment options are going to be limited. The treatments and the treatment options are going to tend to be more limited than average. And I'm not saying that's a bad thing, I'm just saying that's a natural consequence. If you focus on the individual level, you tend to get more options, and it's more focused on personalization of care, which addresses issues like diversity as well, because you're focused on the individual in front of you. Our experience with patient navigation suggests that we need a system that supports shared decision-making that leads to personalized care that is evidence-driven. And a patient needs access to information about risks, benefits, and costs that actually they understand and that matter to them. So what are the challenges to measuring value? And I know the panel after me is going to answer all these for you. Many treatments have high upfront costs that are easy to quantify in dollar terms. The benefits that accrue usually accrue to the individual patient. They're very difficult to identify and monetize over time, and what's the time horizon against which we're actually going to allow those benefits to accrue and incorporate them into the value framework. What patients often value are usually very different than the things that payers and providers and manufacturers value, and this leads back to who's making the decisions about what's in the value frameworks. Patient groups and patients themselves need to fight for the importance of enabling value to be expressed at the individual patient level in addition to the population level. And a much greater emphasis needs to be made on outcomes that this is to Shelley's point, on outcomes and measures that truly matter to patient. We can bring real-world data to these efforts, and the data is what's going to drive the quality measures. It's what's going to drive the incentives. It's what's going to drive the system. And we as patient advocacy groups, through our patient navigation modules, through our survey work, we can bring that data to the table and collaborate with the payers, the providers, and the manufacturers to really help define and recreate a healthcare system that is about value in a way that really matters to patients. So what I would invite all of you to do is, we're doing that in silos. I really think it's an opportunity for the patient advocacy community to collaborate around data. So in the fall, we'll be hosting a real-world data conference. More information to come on that. I hope many of you will be able to participate and to give you a chance to present what you're doing around evidence, hear from the other stakeholders to talk about, well, what are the shortcomings in our data? How do we really use our data to help inform quality measure sets, to help inform incentive payments, to help inform value frameworks? Because I believe that it is actually the data that we have that should be helping to define what the inputs are into these value frameworks and the quality measures, but also our data should be populating those inputs as well. So with that, I'll close and maybe a few minutes for questions. Thank you.
David Leduc with the Adario Lung Cancer Medical Institute. It's not necessarily a question, although you can certainly add your thoughts to it. It was more of a comment of everything that we're talking about today. I've found that patient-reported data and the other things we're talking about today very much is a closed feedback loop. Mm-hmm. To your question earlier about how do we get patients to report and do more, you have to report the results back to the patient. So as we look at these things and we take in this information from data and we take in these surveys, the one thing that doesn't happen the patient never hears the results of
Yep.
that. Not only the results of here's the information I've provided, but here's the changes we've made because of it.
Yep.
And so I just encourage all of us as we consider the data that we're collecting to have this conversation with people about here's what we've learned, here's what we're going to do differently, and then invite public feedback when we're gathering that information as well, because I do think it's a missing piece. Even something as simple as reporting back results of clinical trials to the patients who participated or the people who've answered a survey. It's easy enough to say, you know, you answered this, 48% answered the same, while you're getting the feedback from them. So just a comment more so than a question.
Yeah, and I would agree with you, and this may sound sort of Pollyannish, or I guess, why do we always pick on David-Anish, can I say that? You know, I think and this is a night, it may be a little too blue sky, but I think if we were to allow patient advocacy groups and patients to be part of the process, that whole continuum, and you know, we're not just invited in at certain points, but we're actually at the center of that conversation from the beginning in terms of what's going to be measured, how it's going to be measured, how it's going to be reported out. I think you'll find that the feedback loop will be closed, because we as patient advocate organizations, that's how we think about how we work with our patients. So I think the way to address that is actually, to some of the points that were made up here earlier, is how do we get the patient advocacy groups and the patients involved in these things from the beginning, not as an afterthought, but also reaching back into those communities that we serve through us to help define what those things are. What are the measure sets going to be? What are the variables going to be in the value frameworks? And then the data is coming from those same patients, and then they're bought into it.